to invite the lead discussant of the day, Sajid sir, and the other faculties, the PGs who have joined us, senior teachers, the coordinator of the program, Mohandas sir, and the zonal coordinator, Latika madam, and also in his absence, Ananda Keshavan sir, who is the state coordinator for the event. Now I hand over to Mohandas sir for the further proceedings. Thank you, sir.
Good evening, all. This week we are having the program is arranged by IAP Thrissur, and I would like to congratulate the office bearers of IAP Thrissur, including our zonal coordinator Latika Nair, and also Dr. Manjusha. And this week, the case is being presented by Dr. Muhammad Rishad, who is JR in Jubilee Mission Medical College. And the mentor is Dr. Rose Xavier, Associate Professor, Jubilee Mission Medical College, Thrissur. And the lead discussant is Dr. Sajid Keshavan, who is very familiar to most of the audience here. He is Senior Consultant and Head Pediatric Pulmonology and Critical Care Department, Amrita Institute of Medical Science, Kochi. We have heard him talking in many conferences, and he's a good friend of mine. I usually call for certain doubts regarding some sick cases. So I'm very happy to be part of this program and eagerly waiting for the discussion. Thank you.
You can start with the case, isn't it?
I think we can start with the case. Rishad, you can project the slides.
So is it visible?
It is visible.
Good evening, everyone. Today I am going to present a case of a respiratory distress in an infant presenting from the birth. Presenting the case of a 7-month-old girl child hailing from Thrissur, informant being mother and information reliable. The date of admission of patient was 19th of August 2024 and date of examination was 20th of August 2024. The chief complaints of the baby was complaints of cough since 2 days, fever since 1 day, noisy breathing since 1 day, and fast breathing since 1 day. History of presenting illness. It was a 7-month-old female baby girl who presented with complaints of cough since 2 days, which was sudden in onset, wet type of cough associated with post-acute vomiting, and there were no aggravating or relieving factors, and there was sleep disturbances. Following which, the baby developed fever since 1 day, which was sudden in onset, mild intermittent type of fever with no history of rashes. Following this, the baby had a history of fast breathing in the form of chest retractions, noisy breathing, difficulty in feeding, and excessive crying and irritability. There was no history of runny nose, ear discharge, bluish discoloration of lips or extremities. There was no history of forehead sweating or sucrose cycle. There was no history of lethargy or reduced response or seizure. There was no history of forward body aspiration or drooling of saliva. Coming to the past history, there was no history of previous hospitalization. There was a history of mild chest retraction in the baby noticed from the neonatal period. And there was no history of any drug intake or frequent nebulization in the baby. There was no history of recurrent diarrhea, pneumonia, skin infection, or failure to thrive. Coming to the antenatal history, it was uneventful. Where first trimester, the child is a first child of non-consanguineous marriage. Age of the mother at the time of conception was 26-year-old, and regular antenatal checkups were done. There was no history of hyperemesis, drug intake, bleeding or leaking TB, or radiation exposure. The USG taken was normal, and regular folic acid tablets were taken. Coming to second trimester, the quickening was felt at 5th month, and there was no history of decreased fetal movements. Anomaly scan done was normal. and 2 doses of TT was taken, and there was no history of GDM, hypertension, bleeding, or leaking PV. Third trimester, adequate weight gain was present, and fetal movements were well perceived. Coming to the natal and postnatal history, the baby was born full-term normal vaginal delivery with a birth weight of 3.25 kg, which was appropriate for gestational age. The baby cried soon after birth, and breastfeeding was initiated within half an hour of delivery, and no prelactal feeds were given. Baby later developed respiratory distress and was shifted to NICU, where the baby was on O2 support via NINB, CPAP, and HFNC for a total of 20 days. Due to the requirement of O2 support for an unusually long time, CT just was taken at that time, which showed patchy reticular opacities in the posterior segment of right upper lobe and bilateral lower lobes, and regional hyperinflation in middle lobe and apico-posterior segment of the left upper lobe, findings suggestive of neonatal pneumonia. There was no history of pleural effusion, no pneumothorax or pneumomediastinum, pulmonary interstitial emphysema. Echo done at that time was normal, which showed only patent foramen normal and normal RVLV systolic function. And the diagnosis was 39 weeks, full-term baby with 3.25 kg, female baby with pneumonia. Coming to the diet history, the baby was exclusively breastfed till 6 months of age, and complementary feeds were started at 6 months with banana powder. Currently, breastfeeding on demand and complementary feeds 2 to 3 times a day, getting a total calorie of 606 calories and 12.6 grams of protein. The expected is 592 kilocalories and 12.3 grams of protein. There was no dietary deficiency. Developmentally, the child had attained all the developmental milestones up to the age. Immunization history. Baby was fully immunized, and the last vaccine taken was at the 14 weeks. There was no adverse events following immunization. BCG scar was present on the left upper arm, and no optional vaccines were taken. Family history. It was a non-consanguineous marriage and there was a history of upper respiratory tract infection in cousins. There was no history of genetic abnormalities in family. There was no history of TB, bronchial asthma, or allergy in family. There was no history of contact with TB patient. Socioeconomic status. Father is a software engineer, mother homemaker, belongs to upper middle class as per modified Kuppaswamy scale. Lives in a Pakka house with 4 rooms, and it is a 5-membered family with no overcrowding. And there was a history of exposure to pets, and there was no exposure to firewood, smoke, dust, or pollen, and there was no history of passive smoking. Summary. It is a 7-month-old baby developed and immunized for age with uneventful antenatal period and neonatal pneumonia in the postnatal period, presented with complaints of cough since 2 days, followed by fever, breathing difficulty, and noisy breathing since 1 day, and difficulty in feeding, with a history of family member having a respiratory tract infection. There is a past history of chest retractions noticed by mother from the neonatal period with no dietary deficiency.
Can I interrupt you there?
Yes, sir.
Yeah. So you mentioned about this chest retraction noticed by mother from neonatal period. What do you mean by that? Do you mean that it was right there from neonatal period and persisting throughout, or it was only there transiently during the neonatal period?
So it was, according to the mother, it was persisting after the neonatal period. There was a history of 20 days admission to the NICU, following which child was discharged. Her mother had noticed mild chest retractions from that period itself, and till the presenting time, that is 7 months. Till that, the baby had mild chest retractions.
Okay, so this was kind of like a chronic respiratory history that the mother is giving. Even though
Yes,
the
sir,
baby
yes.
now presented with an acute problem, the mother is saying it's persistent retractions from birth until now.
Yes, sir.
But this particular problem was not affecting with the baby's growth or development.
No, sir. According to the mother, there was actually they didn't consult any other doctors for this because the baby was thriving well, and developmentally also the baby was normal. So in between, there were no other history of hospital admissions also. So and mother thought that chest retractions were persisting because of the pneumonia the child had during the neonatal period.
And what was the more important negative history that you got?
There was no history of runny nose or ear discharge. And
So what did you
there-
mean by when you were asking these questions? What was the differential diagnosis that you're ruling out with your history?
Sir, upper respiratory tract infection, loose discoloration, cardiovascular association, forehead sweating cycle, and lethargy, reduced responses like complications, danger signs of pneumonia, and there was foreign body aspirations since the chest retractions were there. Foreign body aspiration can be also present.
So when somebody has a chronic respiratory problem starting right from newborn age, and then they come to medical attention at 7 months, because that is when things get bad because they probably got a new infection, right? So what are the main differentials you're considering at this point when somebody has a history right from birth, and at 7 months they're persisting with hypoxia and respiratory distress, maybe due to precipitated by an intercurrent infection?
The persistent chest retractions, so it can be present starting from the oral cavity if the child is having a cleft palate or cleft lip, or if there is a laryngomalacia or tracheomalacia or congenital laryngeal valve, or even a recurrent aspiration like GERD, gastroesophageal reflux can also precipitate as a recurrent chest retractions, or any other congenital causes pulmonary chronic pulmonary alveolar malformation that usually doesn't present with state, or congenital lobar emphysema, or any other if the child is having any other inborn error of metabolisms which can lead to metabolic acidemias, or any other cardiovascular causes with the left to right shunt, and increased pulmonary circulations can also present as a large left to right shunt can also present like this.
So you're mainly dividing them into some kind of a underlying cardiovascular cause. That is one that you're postulating. Second group, you would be calling a congenital malformation of either the airway or the lung. That
Yes,
would be
sir.
the second. That includes all your malasias and your fistulas and your stenosis and your everything. And then the third group would be your genetic problems which have early onset in life, right? Like you have a problem with
Yes,
the mucociliary. So did you
yes,
think
sir.
about
Primary ciliary disease. Sir,
panacea and cystic fibrosis?
cystic fibrosis, sir. But the baby is thriving well, sir. And there was no another history of suggesting of cystic fibrosis or primary cellular dyskinesia, because the baby did not have any ear infections starting from birth till now, or any other histories like failure to thrive like that.
Everybody with cystic fibrosis should have failure to thrive? What percentage of cystic fibrosis patients do not have pancreatic insufficiency? Most of the time, the failure to thrive in cystic fibrosis is due to pancreatic insufficiency. What do you think is the percentage of cystic fibrosis patients who don't have pancreatic insufficiency? Guess.
10 to 15%.
Yeah, about 15% of patients with CF do not have pancreatic insufficiency, and they need not have a failure to thrive. So 15% of CF patients need not have pancreatic insufficiency. So just because you don't have failure to thrive, you cannot exclude cystic fibrosis. That's one thing. Second thing is, can you have a relatively symptom-free period in these conditions, or do they always need to have persistent symptoms? So like this is a very short interval, symptom-free interval for this baby. Right from birth, the baby was symptomatic for up to a month of life, and
Yes,
then
sir.
had persistent retractions, and also presented again at 7 months. So you could call a relatively symptom-free interval of 5 to 6 months. Is that
Yes, sir.
very atypical of genetic conditions like PCD or CF, or they are a little atypical? Like what would you do? Does it completely rule out those conditions?
It does not completely rule out, sir, but it is a bit atypical.
Yeah, it is definitely a little atypical, but because the mother is saying there is persistent retractions right from birth, you need to also think about them. But when you have more of retractions and less of cough, because these conditions with mucociliary dysfunctions, immune deficiencies, they actually have a lot of wet cough.
Yeah.
So the cough is a quite predominant symptom in those conditions. whereas predominant retractions would indicate more of a airway malformation kind of etiology to the underlying retractions, right?
Yes, sir.
Yeah. What about conditions which have affect the interstitium of babies? So, are you aware of any condition which can present in the infancy where you can have normal airway, no cystic fibrosis, but persistent parenchymal problems?
Interstitial pneumonitis can be a reason for persistent recurrent cough and recurrent respiratory tract infection.
So these conditions, which are previously being called as interstitial pneumonitis, have been renamed into a separate category. Are you aware of the terminology used for that group of conditions? Previously, they used to be called by different names like chronic pneumonia of infancy and so on. Chronic pneumonitis of infancy, discoemitting interstitial pneumonitis. There were a lot of names being given to these conditions. In the 2000s, a committee has come forward and started calling them by a different name. Are you aware of that name? They come under the category of, have you heard of the term called child? CHILD? So it is a group of conditions which have this triad of chronic tachypnea, hypoxia, and diffuse parenchymal abnormalities. This is the triad of most of these conditions. Most of these conditions start in infancy, and they are called as childhood interstitial lung diseases. This is a term given, a collective terminology given to a lot of conditions which fall under that umbrella, which are actually rare. Like you have your genetic diseases of mucociliary dysfunction, and you have immunodeficiencies. You also have this, some of them being genetic, some of them not being genetic, group of diseases which are clubbed under this etiology of childhood interstitial lung disease. And out of them, are you aware of any particular genetic cause? Any genetic cause of childhood interstitial lung disease that you are aware?
No, sir.
So you know the neonatal respiratory distress syndrome due to surfactant deficiency.
Yes, sir.
Are you aware of anything related to surfactant deficiency as a genetic cause of childhood interstitial lung disease?
Protein transmission.
Yeah, surfactant protein deficiencies can present with childhood interstitial lung disease. As you can also get it in other malformations of the lung, like alveolar dysplasias and alveolar capillary dysplasias. So that is another etiology of childhood interstitial lung disease. So when you consider differential diagnosis for a problem which starts right from newborn period, which goes on until 7 months, kind of a chronic course with acute exacerbations in between, you, like you said, you always think about cardiac causes, cardiac etiology, aspiration related problems, GERD related problems, immune deficiency related problems, malformations of airway and lung. And the last cause would be this group of diseases which have diffuse parenchymal abnormalities. One of these conditions called NEHI. NEHI stands for neuroendocrine hyperplasia of infancy, which is actually probably more common in Caucasians than in Asians, because it's more been described in the Western literature, and not as much I have seen that in India. Is this condition called NEHI, which also causes chronic tachypnea, retractions with intermittent exacerbations and hypoxia. So all of this would be your differential diagnosis for such a case.
Yes.
In your case, with this history of neonatal admission with pneumonia and neonatal CT scans being abnormal, and without any mention of any diffuse parenchymal lung abnormalities, and a relatively asymptomatic period of 6 months without oxygen dependence, what would be your first differential diagnosis based on this patient's history?
Based on this history, it can be like with this long asymptomatic period, it can be a gastroesophageal reflux disorder, uh, continuous aspiration leading to distress retractions, or any other causes like um,
I agree with aspiration. I agree with gastroesophageal. Gastroesophageal reflux is very common in infancy, and a lot of them, even though they have gastroesophageal reflux, they don't actually get gastroesophageal reflux disease. So not everybody with GER gets GERD. I agree, GERD is one of the causes and should be considered. And aspiration related to oral feeding issues also can be one of the differential. Apart from these two, what would be the main abnormality when you consider somebody with a chronic history right from newborn with persistent retractions, with normal growth and no diffuse parenchymal lung abnormalities? It will be airway malformations. Airway and lung malformations would be your main thing, especially because you have retraction. Something related to airway would be your airway would be your main differential for these kind of patients, right? Okay.
Yes.
And now you can continue with the rest of your presentation.
Yeah. Coming to the physical examination, child was alert and tachypneic, and there was no.
Just a few points about the history part. Sajit has very well described the approach, because it was a case with a normal birth weight, gaining weight and development normally, with the main problem of a retraction starting for a long period. That is, in short, in the history, you would have avoided the investigation results and all. When you are presenting in an examination or DNB or medicine or whatever you can get the history from the mother, maybe a little educate the mother also. But padanapadamaയിട്ടുള്ള reports better avoid. The examiners may not like that, and that's not the way, because you are not giving much importance to the investigations. You are trying to get your own approach of the analysis of the problem. So better avoid too much of the investigation results. And in a case when there is a retraction, in the group of conditions, Sajid has well explained the possibility of a cardiac or respiratory, and a group of other conditions like metabolic problems, many other things are already out. And in bone of metabolism responsible for this metabolic acidosis with distress and all are out because the retraction part. So the two systems are most likely out of the system, cardiac and the respiratory system. The respiratory system, Said is very well described. The parenchymal problems are less likely, and more points are for the upper airway anyway. In that group, you mentioned about the cleft palate. Actually, that is not one of the reasons for this situation. Okay. So airway problems are one of the most likely in the assessment. Then in the newborn period, 20 days of stay, Sajis was considering the possibility of a cystic fibrosis. Then neonatal jaundice should have been mentioned in that history, whether it was there or not. And you mentioned about the feeding problem, only the sucrose cycle. Actually, the feeding gives a little more of the information because possibility of an upper problem is there. So what happens during the feeding? Is there a choking during the feeding or after some time? Because GER feeding will be okay, but later aspiration. In an upper abnormality, there are many where there can be choking during the feeding. So apart from the sucrose cycle, other points about the feeding are also important. And you didn't mention about the stridor part. So whenever there is a retraction, there is a importance is the analysis of the sound. Upper airway problems, you expect a stridor. So what is happening to this thing during different positions? Bending, it is worsening. So those points are important. Otherwise, well discussed. So it continue.
Yeah, please continue.
Coming to the physical examination, the child was alert and tachypneic. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema, or no rashes. The vitals were pulse rate was 133 beats per minute with normal rhythm, normal volume character. Peripheral pulses were felt, and there was no radio-radial or radio-femoral delay. The saturation was 94% on 9 room air, and the respiratory rate was 62 per minute, regular abdominal thoracic type of breathing with capillary refilling time of less than 2 seconds, and the child was febrile. Coming to the head to foot examination, the head was the head was normal shape and air was open and level. There was no dysmorphism, facial dysmorphisms. The eyes was normal with no pallor icterus or white spot. Ear was normal. There was no discharges and tympanic membrane was normal. The nose, it was normal with nasal flaring was seen. Lips, there was no cleft lip, no cyanosis. Oral cavity, it was normal with no cleft palate. Neck was normal. There were no skin lesions. In chest, there was tachypnea and chest retractions, mainly subcostal retraction. And the lips were normal. Hair and nails were normal. Spine normal. There was no edema or lymphadenopathy. Coming to the anthropometry, the weight of the child was 6.5 kg, which was between 3rd and 15th percentile, which was normal. The length of the child was 66 centimeter, and it was between 15th and 50th percentage, which was also normal. The head circumference was 41 centimeter, which was between -1 and -2 standard deviation. The weight for length was between -1 and -2 standard deviation. There was no wasting, and the mid upper arm circumference was 13 centimeter. There was no undernutrition. This is the plotted graph of the anthropometry. Weight for age, it was falling between 3rd and 15th centile. The length for age between 15th and 15th centile. Head circumference between -1 and -2 standard deviation. And the weight for length, which comes into -1 and -2 standard deviation. There was no wasting. Inference, the child did not have any undernutrition. Coming to systemic examination, the respiratory system, the upper respiratory tract, there was nasal flaring, there was no nasal discharge, and no septal defect. Throat was normal. Coming to the lower respiratory tract, on inspection, the shape of the chest was normal. It was abdominal thoracic movement. There was subcostal and intercostal retractions. There were no dilated veins, scars, sinus, pulsation, apex plate, and was not visualized. There was no chest wall deformities. Palpation, all inspectory findings were confirmed, and chest movements were equal. And apex plate was felt in the left intercostal space lateral to the mid-clavicular line, and there was no palpable crepitus. Percussion resonate bilaterally over all chest quadrants, and liver dullness heard at the right fifth intercostal space along the mid-clavicular line. Auscultation, there was normal vesicular breath sounds heard, and breath sounds were decreased in the right mammary region, and there was bilateral wheeze and no other added sounds. Other systems, serious S1, S2 was heard, and there was no murmur. GAT, it was soft with no hepatosplenomegaly, no organomegaly, or bowel sounds were also heard. CNS, pupils were equal and reactive. There was no focal neurological deficit. Summary. It's a 7-month-old baby with a history of NICU admission for pneumonia requiring O2 support, presented with the complaints of cough since 2 days, fever, noisy breathing, and fast breathing since 1 day, with significant past history of chest contractions noticed from the neonatal period, and a history of family member having upper respiratory tract infection. On examination, baby was tachypneic with a respiratory rate of 62 per minute, with examination findings of use of accessory muscles and reduced air entry in the right mammary region, and bilateral wheeze was also present. With this history, we come to a differential diagnosis of pneumonia, right side bronchiolitis, and also foreign bone.
Sahit is muted, eh? Sahit is muted.
Yeah, my question is, you have summarized the case and you have put pneumonia, right-sided pneumonia as your first diagnosis, no? What makes
Yes,
you
sir.
say right-sided pneumonia based on your findings? And
Sir, the blood sounds were decreased on the right side mainly, and the child had just a use of accessory muscles and bilateral peace was also present. So, first consideration after the examination was pneumonia right side.
What other findings would you expect in a you mean like a lobar consolidation? Is that what you're referring to? When you say right
No,
sided
sir. No,
pneumonia,
sir.
what are you?
It
what
can
are
be
you-
a mucus plug can also cause a decreased air entry to the right side.
No, what makes you put pneumonia of the right side as your first differential diagnosis? I mean, you have put 3 differential diagnoses, and
Yes,
most of them are acute conditions, right?
Yes,
Most
yes.
of all the 3 that you have put are
acute
acute. So this is on the background of something you mean, right?
Yes, sir. Actually, the present condition was an acute presentation. So we initially with that past history was not. And
So,
so,
so
for
these
the
3, you have put only acute conditions as your differential, and you have put pneumonia as your first, or do you want to rearrange your diagnosis?
sir, foreign body can also cause a decreased air entry to the right side and cause a persistent chest obstruction.
But considering the age of the child,
Bronchiolitis,
does the child have a pincer grasp?
no, sir.
Does the child crawl
No, sir.
and explore?
Mainly we can thought of other siblings, cousins were also present in the house. So mainly by from that, the foreign body can be expected. And
No, but what would you like to put as your first consideration, or would you consider all 3 as equal possibilities, or in considering the age group,
considering the
family
age
members
groups,
having upper respiratory infections, presence of
bronchiolitis,
bilateral wheezing, retractions?
bronchiolitis would be the first consideration, sir.
Can you get asymmetrical findings in bronchiolitis? Asymmetrical auscultatory findings can you get in a bronchiolitis case, or does it always have to be symmetrical chest findings?
So if there is a mucus plug, asymmetrical findings can be found.
So what else would you find in a pneumonia apart from decreased air entry? Even if you go clinically, based on your clinical findings, what else would you find if it is a pneumonia? Like you're mentioning let's say you're referring to a right-sided consolidation. What would you find in auscultation?
Bronchial breath sounds. If it is a dense consolidation, we can hear bronchial breath sounds. And on percussion, it will be a dull note.
Okay, so now this is I mean, acutely there is some kind of an infectious trigger here, obviously from your history, and something has changed dramatically. I would consider foreign body as less likely considering the age and the inability of the child to explore and put something in the mouth. So somebody has to intentionally put something in the mouth for the child to, or mother has to feed something inappropriate for the baby. So that history you will get, and you will hear some kind of an acute choking history because the child would always be fed by somebody. So they would tell you about choking and all of those things, right? You haven't put the chronic diagnosis. So would you want to add something as well?
Yes, sir. Chronic diagnosis also was there. I initially thought of the acute conditions, but considering the past history, you can consider the chronic diagnosis like congenital pneumonia can be considered, but
congenital?
It's congenital pneumonia, but the possibility,
what do you mean by congenital pneumonia? Is that a chronic condition?
A group of diseases like pulmonary sequestrations, congenital open access tumors.
So you mean like a congenital lung or airway malformation as the background, on top of which you have an acute infection, and you want to put, I mean, I would put bronchiolitis above pneumonia at this age, because that's what we see commonly at this age, right? 6 months.
Yes, sir.
You would
Yes,
see
sir.
more of a, and especially you're hearing bilateral wheezing sounds and all, which would be a little bit unusual for you to get in a pneumonia, right?
Yes, sir.
Yeah, it indicates more of a airway problem or a, and this wheezing that you had heard, no? Is it like a polyphonic wheezing or like a monophonic wheezing? What is the difference between the two?
Sir, usually wheezes heard during the expiration.
And what is the difference between a monophonic wheeze and a polyphonic wheeze?
A monophonic wheeze means a single. It's usually heard only during one.
It's not about the phase of inspiration, it's about the pitch. A monophonic and polyphonic is the main difference is the pitch. So if you are blowing on a whistle, you hear a monophonic sound, right? Because that sound is coming from one fixed site of obstruction. There's only one obstruction in a whistle, and that is where the sound is coming from. No, so you hear just one pitch of sound throughout. But a polyphonic sound, the obstruction is at multiple levels, small airway, larger airway, secretions, all of these will create the sound. So you get sounds from different parts of the lung. So you hear a polyphonic wheezing.
Yes, sir.
So which one would you expect in a condition like bronchiolitis?
So monophonic wheeze.
Sorry?
Monophonic wheeze.
No, I told you monophonic wheeze comes from one site of obstruction. Whereas a polyphonic comes from several sites of obstruction. So where do you think the obstruction is in a patient with bronchiolitis?
Yes, sir. Multiple airways are involved, so polyphonic wheeze can be.
So mainly small airways, no? In bronchiolitis,
Yes,
the site of obstruction is small airways, and you have
airways.
small airways in different parts of the lung, and different generations of small airway are involved. You can also get involvement of the larger airways with the secretions.
Yes.
Okay. And and you can also have some medium-sized airway bronchospasm as well. So you can hear sounds from different parts. So you'd be hearing more of like a polyphonic wheezing sound. Whereas if you're getting a monophonic wheeze, you would be thinking more of like one side where it is coming from, right? So something like a large airway obstruction or something like that, right? That's where the sound is predominantly coming, and it's being conducted all over the chest wall. That's what you would hear, right? Even in a foreign body, would you hear a monophonic wheeze or a polyphonic wheeze?
Monophonic wheeze.
Yeah, because it is coming from that site of obstruction, right? And it is usually, unless it's a central airway foreign body, a foreign body as well, you would hear a localized wheezing in one side. But you can have central airway foreign bodies which can give you bilateral findings as well, right?
Yes, sir.
Okay. Well, you didn't consider asthma as one of your differential diagnoses. Why so? What if I say this child is having an asthma exacerbation? What are your points against it?
There was no family history. And there was no previous history also. Previous history of nebulizations or previous hospital admission with similar complaints. And history of atopy was also not there.
And this is the first episode of wheezing in this child, right?
Yes, sir.
This is the first episode. There's no previous history of wheezing in this child. And how was the response to the nebulizations for this child? Did the child respond very well to the nebulizations given during the hospital stay, or did not respond?
No, sir. Initially, it didn't respond as fast as like other bronchiolitis cases. Actually, there was a prolonged hospital stay also.
So you mean to say that bronchiolitis cases respond well to nebulizations? Is that what you're saying?
No, sir. No, sir. Purified oxygen is the mainstay of treatment. But there is no role for nebulizations in bronchiolitis.
Okay. Yeah. So regarding the growth of the child, you mentioned the growth is normal. What is the significance of growth assessment in such a patient? Apart from the fact that you are considering differential diagnosis like cystic fibrosis, which have coexisting malnutrition, What is the significance of growth assessment in such a patient?
So, failure to thrive as such can cause persistent chest contractions. Because, if there's something like cardiovascular causes, the child usually fails to thrive, and it can also, if the shunt is pulmonary shunt is more, then it can also present as tachypnea and
Yeah,
mild chest
I
contractions.
agree with the cardiovascular causes has to be strongly considered in a 6-month-old child who has failure to thrive, chronic retractions. A cardiovascular cause would be, especially a left to right shunt causing
Yes.
heart failure, chronic heart failure would be a predominant cause. Any other reason why growth assessment is important?
So, immunodeficiencies.
Yeah. So if there is a significant genetic problem with immune function, you would expect. I agree. What else? What if you didn't have any of that? What if you just had an airway problem? Can you have failure to thrive due to, let us say this baby has laryngomalacia,
Yes, sir.
severe laryngomalacia. Can a severe laryngomalacia at 6 months give you failure to thrive?
So it can happen. Severe
If there is
laryngomalacia.
significant work of breathing, right? Like it will
Significant,
not
sir.
cause failure to thrive without significant work of breathing. So if a lot of energy is spent,
required for that work of
so that can cause failure to thrive issues. So that is the importance of growth assessment. And the head to foot examination, can you go back, please? Head to foot. Yeah. So what are the main things that you would want to look for in such a patient in head to foot? Negative.
Sir, mainly ear. We look for any discharges or any ear infections and lips and oral
What do
cavity.
they point to?
Sir, chronic means upper respiratory tract infections indicating like cystic fibrosis or primary ciliary dyskinesias.
Apart from that? What if you had a significant rash right from newborn period and you also had chronic draining ears when failure to thrive?
It can indicate immunodeficiencies symptoms.
Yeah. Then any other condition that you will think of? They're rare conditions, so you will be excused even if you don't say them. I can check with Purushothaman, sir. Sir, in the head to foot, can you think of any other things that is important, sir?
The pointers make the susceptibility for infections, as Sajid was rightly pointing out. Immunodeficiency situations pointers. In the history, there is no bowel disturbance, ear discharge, purulent nasal discharge, and skin and abscess situations. So that means there can be 3 situations. One is a generalized immunodeficiency. The second one, the pulmono-respiratory unit problems. So if it is a lung infection only, you need to consider malformations of the lung or airway or a cardiac problem. If that's a combination with the upper airway also, there are other possibilities like ciliary dyskinesia or the cystic fibrosis like situation. So the pattern of the infections we will give a clue. In the general examination, you rightly mentioned the dysmorphism, genetic problems are not there, other points of infection are not there. And Sajid was pointing out to one condition which you didn't answer. When there is a skin lesion, ear discharge, suppose there is hepatomegaly also in that situation. Anything like a malignancy, Langerhans cell disorders.
Yes, sir.
That is to be considered. Okay.
Thank you. So from your diagnosis, Sir Purushothaman, sir, your comment on that as well. He mentioned pneumonia, bronchiolitis, and foreign body as the differential diagnosis.
Yes, I agree with that because there is a evidence of bronchospasm, but that doesn't explain the long duration course. the indrawing from the newborn period is not explained by any of these acute problems. So there can be a chronic problem over and above some acute problems has occurred. So, and there is an indrawing, the malformations of the upper tract, or rarely the possibilities are lower things like sequestration or diaphragmatic hernia or a CCAM or something like also need to be considered. It's not a acute episode only. There is a chronic problem over and above some problem has occurred. I agree.
Go to your system examinations, please. Next, please. Yeah. So you mentioned that this patient had in the newborn period there was overinflation of the right side, right?
Yes, sir.
And when you examine this patient, I mean unbiased, you didn't feel any difference between air entry of the right versus left, or any difference in the resonant note heard over both chests?
Sajid, I have a doubt to ask you, because you have worked many years outside. What about the percussion in the very younger age group? Will they accept that a newborn baby being percussed for a diagnostic purpose? And what is the cutoff age period where they will be considering this thing in other countries, MRCP examination and all?
So we do this finger percussion rather than the two-handed percussion. That will be allowed.
In a 6-month-old baby, it's okay. But if it is a younger baby, they
neonatal examination, they don't keep small babies for MRC membership exams for respiratory system. So I'm not really sure about the code of conduct there, but it is the examination format is uniform across age groups. Percussion becomes part of the respiratory system examination. So even if you cannot do with finger over finger tapping, you can just tap with your finger alone and then hear the resonant note. And it is actually very easy to percuss even in small babies. And with small gentle percussion itself, you can hear a note that you don't need to really
information with the percussion part will be definitely useful. Only thing, it should be very gentle.
Yeah. So you want to discuss further, Rishad?
Yes, sir. I'd like to continue the
continue with the presentation.
Sir, the course in the hospital. The baby was admitted in ward for the above-mentioned complaints and was started on O2 via CPAP, IV fluids, nebulizer, and other symptomatic medications. Relevant investigations were done, which were as follows. The relevant blood investigations done almost normal. It was normal with a lymphocyte predominance, and inflammatory markers were also normal. And a chest X-ray was taken to the child, which showed right lower zone bit of collapse consolidation with the infiltrates in the right upper and left upper lobe.
So my suggestion is, whenever you read an X-ray, don't start with diagnosis first. You describe what you see and describe what you see in terms of abnormalities. A black abnormality you call as lucency, and a white abnormality you call as opacity. So and also always comment on the mediastinum, whether it is shifted, and overall volume of the lungs, what it feels like, along with soft tissue and bony lesions. So you won't miss anything. So if you want to start with soft tissues and bone, looks fine. Technical quality of the X-ray looks reasonable because it looks really well positioned with good exposure. So coming to the soft tissues and bones, you don't see any major abnormalities. Then you can comment on the mediastinum. So what do you think about the mediastinum here?
The mediastinum is slightly shifted to the left.
Okay, so there is a mediastinal shift to the left. And when you look at the other borders that you normally see on an X-ray, you would see the right diaphragm, you would see the left diaphragm, you would see the left heart border, you will see the left superior mediastinal border, and you will see the right superior mediastinal border. So among these borders that you normally see, is there any abnormality in any of these borders?
The right heart border is not.
Yeah, the right heart border is not seen, but that can also be because it is pushed behind the the sternum and between the sternum and the vertebra. So that is because of the mediastinal shift as well. Any other abnormalities that you see in any of these borders when you compare right with left? What is your comment on the right diaphragm versus the left diaphragm?
So right diaphragm is a bit downwards compared to the left diaphragm.
Yeah, it's almost flat, right? It's the dome is
Yes,
missing, right? So the right diaphragm is flat, and it looks like it is pushed down because it is flat. So it's hyperinflated right thorax, right?
Yes, sir.
Yeah. And then what do you think about the lucency versus opacity? So here, whenever you read any X-ray, X-ray is a black and white picture. So there are normally black structures and normally white structures in X-ray. So you would want to call an abnormally black structure a lucency and abnormally white structure an opacity. So there are two ways that you can call this. Either you can call the left-sided, left upper and lower as abnormally opaque, and the right as normal, or you can call the left upper, left lower and right lower as normal and the black thing lucent. So which one would you call which? Would you call it, would you think the black areas are abnormal here or the white areas are abnormal here?
Both the black areas and the white areas are also.
Yeah, so what is the abnormal black area? So that's a lucency, right? Where
Yes,
is
sir.
the
It is
abnormal
a
black area
hyperlucency.
seen?
Sir, in the right middle lobe, there is a hyperlucency, right?
So don't call it middle lobe. You can say right mid zone or right
mid zone.
There is a
Yes, sir.
abnormal lucency, and you call it a lucency because you can't see much of lung vascular markings there.
Vascular
You can
markings.
see that the vascular markings of the lung are pushed up and down. So you can see that they're crowded towards the hilum, no? So it's almost
sir.
like something is pushing them from down and above, right? So the
Yes, sir.
vascular markings above are pushed to the closer to the mediastinum up, and they're pushed closer to the mediastinum down, and there is something which is loose and occupying there. And you can see that that lucency is also looking like it is herniating to the other side.
Yes, sir.
Yeah. And on the left side, you will see there is opacity, mainly in the left upper zone, right?
Upper zone, yes.
Yeah, so that you call as opacity because you're seeing a relative paucity of air spaces there because of more whitening there, right? And
Yes,
the left lower zone you would be calling as normal.
Left lower zone also opacities. Left lower zone also mild opacities.
No, I mean, you have to call something as normal. Everything you want to call abnormal, like whenever something is abnormally black and something is abnormally white, there is something which is normal. So in this, the normal
comparing
lung
this
like left lower zone.
In this X-ray, the left lower zone appears to be normal.
Yeah. So the relatively preserved area seems like the left lower zone. Left upper zone is opacified. Right mid zone is lucent. And right lower zone, especially that right lower lobe, is also opacified. You can see that line which is going from your middle of the mediastinum down to the diaphragm, and you see the triangular structure which is there that you see through the lucency. That is the right lower lobe. Right upper lobe has been pushed up, and the left upper lobe has been shrunken, and the left lower zone seems okay. And there is this abnormal. So what stands out is this abnormal hyperinflation of the right side with an abnormal lucency occupying the right mid zone. And you can call it a collapse of the right lower lobe and maybe left upper lobe as well. Right?
Yes, sir.
So based on this, now you want to say your differential diagnosis again?
Yes, sir. Based on this.
When you see this X-ray, what is the first thing that comes to your mind?
Initially, when I saw this X-ray, first the thought was of the foreign body.
Why did you think about foreign body?
There is a regional hyperintensities in a single area, and other area is being opacified.
Okay, so something which is causing a ball valve effect, right?
Yeah, yes, sir.
Yeah, so which is allowing air to go in,
But
but not allowing
it's
air
not
to come
allowed.
out. So
Yes,
you're
sir.
thinking about a foreign body. Okay, fair enough. So what else? What about your pneumonia and your bronchiolitis diagnosis? Is this
So,
X-ray compatible with them?
So this X-ray is not compatible with the bronchiolitis, but we can call it as a pneumonia of right upper zone and right lower zone.
Sorry?
Patchy opacities are there in the right upper zone and the lower zone. So
So
pneumonia
do you
can be
see this kind of a hyperinflation when you have consolidation of right upper lobe and right lower lobe? No matter how much your right upper lobe and right lower lobe is consolidated, you will not see a middle lobe which is so emphysematous. So that does not explain. But obviously, a collapse can cause compensatory hyperinflation, but a
Yes.
consolidation or a pneumonia cannot explain this hyperinflation of the right mid zone, right? And a
Yes, sir.
pneumonia of the right upper lobe and the right lower lobe will not cause a mediastinal shift to the opposite side. So
Yes,
you
sir.
have to think about an etiology which is causing a mediastinal shift.
Yes,
So there are two reasons of mediastinal shift to the left. One is abnormalities in the right side, which is pushing the mediastinum to the opposite
to
side.
the opposite side.
The other is a pathology in the left side, which is pulling the mediastinum
Pulling.
towards the same side. Now, how do you know which is which?
In this case, I think the right side of pathology is pushing the mediastinum to the
Why do you think
left
so?
side. So there is a clear-cut hyperrecency in the right side.
So it's
Can,
mainly because of your findings, right? You found
yes, sir.
air entry was decreased on the
Decreased on
right
right
side.
side.
So the air entry is usually decreased on the abnormal side,
Yes, sir.
right? Yeah. So here the pathology is on the right side. So the right-sided pathology is pushing, and a consolidation cannot push, right?
Yes, sir.
Yeah, so what can push? What all can push mediastinum?
So the mediastinum can push the mediastinum to the opposite side.
So pneumomediastinum does not push mediastinum to the opposite.
Sorry, sir. Not pneumomediastinum, sir. I meant pneumothorax.
You meant tension pneumothorax.
Yes, sir. Yes.
Yeah. Why do you think this is not a tension pneumothorax of the right side? So that can explain, like if you have a pneumonia on the right side and you develop a pneumothorax as a complication, that can push mediastinum to the opposite side. Why are you not thinking about of a pneumothorax when you see this X-ray?
Because it's usually an acute condition. It progresses
Sorry?
drastically. Acute conditions, it progresses drastically very fast.
So what do you mean drastically? This child has tachypnea, hypoxia, respiratory distress, and decreased air entry on the right. Why can't it be a pneumothorax? Like what makes you say based on this X-ray that this is not a pneumothorax?
Sir, the upper lobe and the upper zone and the lower zone, it's not pushed completely.
So it's mainly because you can see lung markings up to the periphery
Yes.
in the upper and mid zones, and
Yes,
lung
sir.
markings are basically absent in a very less area, right? It's in the lower two intercostal spaces that you don't have lung markings, but still loculated pneumothorax can present like this, right? Like a general tension pneumothorax will not have, but a loculated pneumothorax, which is very unusual to get a loculated pneumothorax without having any empyema or anything like that, right? Like so, less chance of a tension pneumothorax, but definitely something that you should always consider when you have a mediastinal shift with lucency is pneumothorax. But though this X-ray it looks less likely. So what else other than pneumothorax can push mediastinum?
Sir, emphysema, single-sided emphysema.
Okay, a congenital lung malformation, which could either be a lobar emphysema or any kind of a mass there, like a CPAM or something, can also cause this mediastinal shift to the opposite side. So a lung malformation, which is a cystic lung malformation or a loosened lung malformation, can push. What else?
Sir, any mass space mediastinal mass?
But mass would not be loosened, right? So
yes, sir. It won't be loosened.
Loosened masses are congenital. So give me 4 examples of loosened masses which can push mediastinum apart from CPAM and CLE. So you mentioned CPAM, which is congenital pulmonary adenomatoid malformation, and congenital lobar overinflation, which is CLO or CLE as it was called before. What are the other 2 cystic malformations which can be present and can push?
Sir,
Belongs to the same category.
Bronchiectasis.
Bronchogenic cyst and
Bronchiectasis.
not bronchiectasis, sequestrations. Sometimes
Pulmonary
have a cystic component of sequestration, which can also have a mass effect and can push mediastinum opposite. So when you consider these 4, based on this X-ray, which one would you think about as your first differential? Among these 4, CPAM, CLO, sequestration, bronchogenic cyst.
Among these 4, I will consider congenital lobar aneurysm because in congenital pulmonary airway malformation, it's usually like a large macrocystic or microcystic lesions, and pulmonary sequestration also it can be like a loculated lesions on the right side. But here it is like a more of a diffuse area of hyperresency which is seen.
Okay, so you're thinking more of like a congenital lobar. And which lobe do you think is involved based on this X-ray?
So most probably it will be like a middle cells.
Okay, so you think it is a right middle lobe, which is so what would be the most crucial investigation for this child, or what is the next step for this child after this X-ray for you to come to your diagnosis?
So we can take a CT of chest or a ventilation.
There's one more thing, you should always compare with previous X-rays. Whenever you're entertaining a diagnosis of a congenital lung malformation, when you have an acute presentation, should always ask for previous X-rays and compare with previous X-rays and previous imagings, because it will be very unusual for you to have a new X-ray abnormality, which was completely not there in previous X-rays when you're dealing with a congenital lung malformation. If it's a significant congenital lung malformation, you should have some radiographic abnormality which has been there from before. It may not be as evident as it is now, but you always retrospectively find something. So review of previous X-rays is very important in such a patient.
Yeah.
Do you have any previous X-ray for this child?
Currently, previous X-ray is not there, sir, but previous CT chest also showed a mild hyperinflation in the right zone area.
Okay, so that tells us that this hyperinflation was there even in the newborn period, and it is there even right now. Okay, so that brings you more closer to your possibility of having a congenital lung malformation, which for this child, right? So the next investigation is what is your next investigation for this child?
The CT of chest can.
CT.
Yes, sir. CT chest or
plain CT or a contrast CT or a angio CT? Which CT would be best?
HRCT, high resolution.
So most of the time when you have a question like that, I think the safest answer would be I'll discuss with radiologist and decide. But if you were to pick one, because there's some of these imaging choices, especially in children, you don't want to do repeated radiation exposure. So you want to do everything in one radiation exposure. So it is the best answer probably is I'll discuss with radiologist as in and give them my differential diagnosis and ask their opinion on which is the best CT modality to be used, whether we would do only a HRCT chest or you would do a CT chest with contrast or you would do a CT chest with angio. Most of the time when you're dealing with congenital lung malformation, a CT chest with angio is the most useful investigation rather than anything else, mainly because you want to see the feeder vessels, the blood supply. So because sequestrations will have blood supply from the systemic side. So the CT with maximum yield would be a CT chest with angio.
Angio.
But that again needs anesthesia and other things to do. So whether we do it or not will depend on the hospital that you are in and the setup that you have and the anesthesia support that you get for doing these kind of cases. So the answer is basically you will discuss with the radiologist about the best modality of CT to be done. I think for a PG discussion, these are the main points. We don't need to go into, or maybe one more question I can ask. Suppose it is proven to be a congenital lobar emphysema in a 7-month-old baby. What is the treatment?
Lobectomy.
Can you leave it without any intervention? What is the natural history of these conditions?
So if in congenital lobar emphysema, if the child is worsening, we will consider lobectomy. Lobectomy is the main treatment for.
They're symptomatic and they're present. Most of the congenital lobar emphysemas will be symptomatic in the newborn period. Like this patient also had symptoms in the newborn period. So if they become symptomatic right from newborn period, then they need surgery. But things which are incidentally detected, which don't cause much symptoms, can be left alone without operating as well. So as long as they are not affecting with the growth of rest of the lung. Suppose it is continuously causing collapse of the right lower lobe and right upper lobe, then it might have to come out. But sometimes there is a lobar emphysema, but it is not causing collapse of rest of the lung, and the patient is growing and not symptomatic, then you can actually leave them alone. So not every lobar emphysema needs to be removed. They should be removed if they cause symptoms or significant mass effects and affect the growth of rest of the lung. That would be the answer. Yeah, so that is my discussion. Anything to add, other senior faculties or any questions to ask? Rishad, please carry on.
Well discussed, Said and Mohammed. In the clinical examination, when we finish the examination and you have seen the X-ray, we rewind and go back in your examination respiratory. In the respiratory system examination, what was your finding of the percussion, air entry, and other thing in the clinical examination? Which all areas, area-wise? Rather than right side, which are the areas you found abnormality? What was you mentioned the percussion as hyperresonant? No?
No, sir. Usually in such cases, we usually get a hyperresonant percussion.
Yeah. What was your finding?
Sir, it was resonant in all chest quadrants.
All areas resonant. That is what you
mentioned. Yes, sir. Yes, sir.
I thought it was impaired or something like that. It was resonant. Normal.
Yes, sir. It was.
You wouldn't elicit hyperresonant. We don't expect also, unless you know the diagnosis. But impairment is unlikely. Intensity, all areas were diminished. In the back and the front also, mammary area, infrascapular, axillary area, all reduced or front only?
Sir, no, sir. Mammary areas were only
in the front and axillary area, inframammary and axillary. Back was all right.
Yes, sir.
Okay. So once we have finished we have seen the X-ray and discussed the finding, most likely correlating with the clinical finding. Just like as I already pointed out, there are two possibilities, whether it is on the right side or left side, push or pull. You utilize the clinical finding are on the right side, so you go with that. Now is the explanation of the unexplained reason. Since birth it was there, something was there persisting. So that is the point. In this X-ray analysis, you considered all the four possibilities, like your emphysematous lobe due to foreign body you considered pneumothorax, you considered the malformations. So here comes the points for the malformation, because if it was an foreign body or an acute onset pneumothorax, it will not be there since birth. So there was a documented finding with the investigation in the newborn, and now as Sajid was pointing out, if you are having a repeated images, if it is occurring at the same site, would have had. Here you had a CT documentation and the findings on the right side in the newborn period. Again, you are getting all the findings on the same area. So all the points are points for a malformation. Which is the malformation? One most important possibility in the sequence, the left upper lobe is the commonest of the site for congenital lobar emphysema, then the right middle lobe. And the least, I think, is in the left lower lobe. So it's again possible for the congenital lobar emphysema. The cystic, the sequestration lobe, cystic variety, I think it's not that common. So commoner one always is congenital lobar emphysema. So most likely that is the person. Well discussed, Sajita, and you also answered very well.
Thank you, sir. Is there any other seniors who have joined who would like to offer the? What about the mentor from?
Rosa, we didn't. Vinod sir and Rosa.
Sir, I'm here, sir.
Yeah, please offer your comments.
So it was an excellent discussion, sir.
No, but anything you want
Very
to add on the
informative.
patient's course, which, like, you had any diagnostic dilemma or?
Sir, like Rishad said earlier, the mother said there were chest retraction since birth, but we didn't rely so much on the mother's statement. We thought she just said it, it was her impression. But when the child had a prolonged course, that's when we reworked. I mean, we went back to the case, and when we saw the x ray, we had a doubt that this could be a case of a congenital lobar overinflation.
Did you
Which is
take
when we send the patient to you, sir.
Did you take a lateral view, Rose?
Sir?
Did you take a lateral view? Is there any lateral view available?
No, sir. We didn't take a lateral view, sir. When the child was taking a long time to come off oxygen, come off HFNC, we repeated the X-ray to see if there's any worsening. But the X-ray was similar. So that's when we had a doubt whether this could be a case of a.
Can I make a comment?
We didn't have the neonatal CTs. When we have a patient like this, it is a little bit of a dilemma for us as well, because the question is chicken and egg scenario. So if you're getting,
Sir, am I audible?
if you're getting some kind of a bronchiolitis with multilobar collapse, and is the collapse of the right lower lobe and right upper lobe due to mucus plugging causing compensatory hyperinflation of the right side is always a question. And then we'll always think about this anything obstructing intraluminally, so we might have to do a bronchoscopy and other things. So because we had a clear documented CT scan from newborn period, it was very easy for us to make a decision and proceed with lobectomy. And after lobectomy, the child came off oxygen very smoothly. Because if it was the other way around, if it was actually a compensatory hyperinflation of the right middle lobe due to collapse, chronic collapse of the right lower and upper lobe, which can happen in some conditions like ciliary dyskinesias, where mucociliary dysfunction is there, you can have those things. Then we would actually, by removing that working lobe, the child would get worse. So whenever we do this surgical decision making of congenital lobar emphysema in an older patient, it is always tricky. In the newborn period, it is a very straightforward choice because at that point there is hardly any differentials involved. But when you have a patient who is coming at a later age and without any prior radiographs, it can be tricky.
What about the one point we couldn't completely possible? The left upper zone haziness, how far it is due to push only? Is there any reason for that? Is there a collapse underlying? Should we go ahead with a scopy also before a surgical thing?
No, sir. When we have this right middle lobe, so this is actually a very underestimation of the actual hyperinflation. When you see the CT scan, you will see that anteriorly, the right lower lobe will go as much, so the right middle lobe is so emphysematous that it goes to the left side, and whatever you are seeing on this as herniation to the other side is quite an underestimation. So it is the overinflation of the right middle lobe itself, which is causing this collapse of the left upper lobe. On CT scan, we can also see the intraluminally if there is something. So what we saw in this patient CT scan was that the trachea and the main bronchus and the subsegmental bronchus were all patent. So, and when we see that this is herniating, then we don't always do a bronchoscopy, especially because we had a neonatal CT in this case. If we didn't have a neonatal CT or imaging in this case, definitely we would have done first a bronchoscopy and then only we would have done a lobectomy. In this particular case, we did not do a bronchoscopy. And the left lung expanded after the right middle lobe was removed.
Das, your comments, please.
It was a well presented and a very nice discussion. One comment is regarding the use of since. You told the child is having fever since 2 days, cough since 1 day. So it will a better use will be for 2 days, for last 2 days like that. You can say child had problems since birth like that, but since 2 days, I don't think it is a correct use. And another thing is, what was the birth weight?
3.25 kgs.
Huh? Hello?
3.25 kgs.
The baby was having good weight. And how was the nutrition?
Sir, child was getting adequate nutrition.
Okay, with a very good birth weight and with adequate nutrition, there was around 1 kilogram weight less for this baby by 6 months. So even though it falls within between first and second standard deviation, and with the complaint of lower chest indrawing persisting throughout, I think these 2 points you could have highlighted to say that child is having a chronic problem rather than just making a diagnosis of pneumonia. Child had a problem in the newborn period. Mother complains that there is a persistent chest indrawing. And despite a very good birth weight and a proper nutrition, child has not gained weight as expected. So even though it will fall within normal range, you can't call it as malnutrition. So all these points you could have used to think of a chronic problem. That's what I felt.
Thank you for the discussion, all seniors in the group. And thank you, Rishabh, for the great choice of case, as well as you did a fantastic job with putting up the case and presenting in a very nice way. We can stop maybe.
Thank you, Saita. Srinivasa sir undo indu sir vannu.
Sir illa
innu korchu number aalkare korva. Appo Das, we can wind up alle.
We can wind up. Thank you, Dr. Sajid. Thank you, Dr. Rose. Dr. Rose ne initially vilikkan vittu poi, sorry.
Yes, sir. I was there at the beginning.
Okay.
Thank you, sir. Thank you for giving us the chance, sir.
Thank you.
Thank you.
Latika, formal ആയിട്ടുള്ള ഒരു vote of thanks വേണോ? ലതിക ഉണ്ടോ?
ഇനി വേണോ സർ? എല്ലാം താങ്ക് യു ഒക്കെ കഴിഞ്ഞു.
അല്ലെ അപ്പൊ ഓൺ ബിഹാഫ് ഓഫ് ദിസ് നമുക്ക് എല്ലാവർക്കും ഡോക്ടർ സജിത്ത് ആൻഡ് ജൂബിലി മിഷൻ സ്റ്റാഫ് മെമ്പേഴ്സ് എല്ലാവർക്കും കൂടി vote of thanks അല്ലേ? താങ്ക് യു.
We rarely have respiratory cases like presentation like കുറവാണ് actually. We should have more respiratory cases. So
എക്സാമിനും ഇത് തന്നെയാണ് വേണ്ടത്, ക്ലിനിക്കലിയും ആവശ്യമുള്ള
വരുന്ന പകുതിയിൽ കൂടുതലും റെസ്പിറേറ്ററി അല്ലേ വരുന്നല്ലേ?
പക്ഷെ ഈ പി ജി ഡിസ്കഷനില് റെസ്പിറേറ്ററി ന്യൂമോണിയ എന്ന് പറഞ്ഞാൽ അതിനെ സിംപ്ലിഫൈ ചെയ്യും, ബട്ട് ഇറ്റ്സ് നോട്ട് അറ്റ് ഓൾ സിമ്പിൾ.